The ADA-EASD consensus report on the management of hyperglycemia in people with type 2 diabetes was recently released. I'm not going to review the whole report today, however, and I would encourage you to read it. But what I'm going to talk about is what does it mean to my patients who were treated in an under-resourced setting in East Los Angeles. First off, I think it's really important to note that the title of this report still says management of hyperglycemia. And we know now that we have many drugs that were created to treat type 2 diabetes that do much more than treat hyperglycemia. And that includes the GLP-1 receptor agonists and the SGLT2 inhibitors. So when you're writing these algorithms, it becomes very hard because different people with different risk factors need different agents. But there's a real problem because those agents are more expensive than the generic agents we've had around for a long time. There are many under-resourced settings where those drugs aren't on the formulary and we can't afford them yet, or we can only afford them for a smaller subset. So first, when we look at the glucose-lowering medication category on the overall figure for managing hyperglycemia, it's very non-proscriptive. It basically says, look at the patient and try to choose the best agent for glucose lowering. And I can't argue with that, but I can say that that doesn't really help my providers who work in a setting where they can't necessarily choose amongst all the agents. So what I think is really important is as follows. First, in the guidelines throughout, they talk about putting the person with diabetes at the center of care. And I couldn't agree more, because that person may or may not be someone like me. These are people who may live in very different settings. They may have many issues that are involved with the social determinants of health. They may have food insecurity. They may live in a place where they can't exercise. They may have all sorts of worries about losing their job, about becoming homeless, about dealing with sick family members. There are a lot of things that exist in our patients' lives that we need to understand. So I think part one is understanding your patient. Because if you start discussing using a drug like a GLP-1 receptor agonist that's completely unaffordable, it's actually not doing your patient any service. But I do think we can do a lot of good for our patients, even with very limited resources. So when you look at figure 4 in the guidelines, it's called a holistic person-centered approach. And in the very middle, there's a person as a figure. And around that person are all these blue boxes. And those really represent all of these social determinants of health and concerns that we really need to think about when treating a patient with type 2 diabetes. Around that is a circle that goes into whether or not a person has pre-existing cardiovascular disease and or CKD or heart failure. And then in my world, a very small portion talking about the standard treatment we have for patients. And that standard treatment is comprised of medications that are generic and that really help. So first of all, when we have a patient with type 2 diabetes, starting a statin is an easy first step in terms of lowering cardiovascular disease risk. And many patients aren't started on statins who need to be on statins. So step 1, start a statin. Step 2, measure blood pressure. Again, a low-cost way to treat our patients. And there are many good generic drugs for lowering blood pressure. And by giving a statin and treating blood pressure, we can actually prevent cardiac disease and renal disease. And I think we need to remember that those first basic steps are as important as anything else we can do later, and frankly, later means that someone already has complications. In terms of glucose lowering, metformin works. It's been well tested. We've had it out since 1957, and we're very used to it. It doesn't cause hypoglycemia or weight gain, and no, it's not going to cause weight loss, which is a goal in our patients, but it does help control glucose. And then, as for next steps, well, you can use a sulfonylurea agent. In the GRADE study, they worked. It may not be as good as a GLP-1 receptor agonist, but the differences weren't huge. And yes, sulfonylurea agents can cause hypoglycemia and some weight gain, so I tend to use them at a lower dose. I also educate the patient as to potential side effects, but I can get many patients down to a reasonable A1C. And more important than anything is not to let therapeutic inertia sink in. And that's a problem in all of our patients. You need to really be on top of the patient, look at their A1Cs, and add a new therapy when they're just a little bit above their target and get them down below their target with each new step. Now, if that doesn't work, in my world, I can add in pioglitazone because it's generic, although I don't tend to use higher doses because I'm concerned about some of its side effects. I can add in NPH insulin if I need to get someone down, at least in terms of just having them on bedtime insulin. But again, you need to educate the patient, discuss the risk of hypoglycemia and targets, and really work with the patient to achieve these goals and to continue to keep them at these goals, because you really want to be sure that patients are followed over time. And that gets me to the concern about access. One of the problems I see over and over again are patients who lost access to healthcare, who then fall off their medications, who end up coming back years later with terrible complications. So I think finding ways in communities to promote and help people with access to healthcare is really important. And also to educate patients that they need to really work to find access insofar as they're capable, because they need to be on those medications we just mentioned. I do think that we need to work with health plans, with whatever your safety net providers are, to see if it's possible to get some of these newer drugs on the formulary. We've been able in LA County to get SGLT2 inhibitors and GLP-1 receptor agonists on the formulary for people who have high-risk characteristics, and I'm very proud of that, because now I know I can use the drugs that I need to simply get patients under control and add to their therapy newer agents once complications develop. So I just want to say that I really commend the work that the committee did in terms of looking at all the options and looking at the best scientific data we have for treating patients. But don't ever forget that it is your patient who matters most, and that our patients may need a social worker. They may need someone just to listen to them. They may need all sorts of help dealing with the social determinants of health, which impact how they live. And that if you don't do that, you're never going to get them even on the basic treatments that we now have available. So work with your patients, remember who they are, and I am optimistic that I can make a big difference in terms of managing their diabetes and cardiovascular risk and helping them avoid developing the complications of diabetes and hopefully live a longer and healthier life. Thank you.